Hi guys, thanks for tuning in. My name is Dr. Omer, and we've got Valid here.
Hi guys.
I'm a GP in Manchester, and we are essentially trying this almost a bit experimental section out called Consulting Room Pod, just to share some of our experiences. My background is I lead the clinical department at a national company called Valor, which supports primary care with the clinical and their administrative workload often. And then we've got Valid as well. Do you want to just share your background a little bit?
Yeah, so guys, I'm Walid Ghafoor. I'm a GP partner in Manchester and the CEO of Vala.
So hopefully you've seen some of our other episodes where we talk a little bit about experiences, about ongoings within the NHS, and actually we've had some great interaction. Actually, also some of our viewers who've sent across some of the questions and wanted us to do a bit more of a quick fire round here. So I've got a couple of questions here from the public, essentially, that I'd love your opinion on, Walid. How does that sound? Yeah.
Yeah, sounds good.
So first one, quite in theme. Why can I never get an appointment?
Probably because there aren't any. Is the
All right,
honest answer.
that solves that one.
That's a relatively straightforward one.
Yeah.
So we're not really allowed as GPs to hold appointments, right? So if there's an appointment available, it'll be offered. But given the breadth of staff working in a surgery, I mean, the day of there's 5 consulting rooms and every room has a GP are kind of gone, right? It's very unusual to find that sort of setup. If you walked into an average surgery with 5 consulting rooms, you would probably find 2 of them had a GP in them, one of them had a nurse in them, one would have a paramedic, and one would have like a physio. Like as an example, that's what a room of 5 might look like.
Yeah.
So the issue with that is, because there's lots of positives to that, which is why it's happening. But the issue with that is the physiotherapist is only going to see physiotherapy things, and the paramedic is only going to see things appropriate for a paramedic.
Yeah.
So what you end up losing is versatility, because if you had a room of 5 GPs, then anything could get seen by anyone, and that's what we lose. So sometimes, especially towards the end of the day, you might have a certain number of GP appointments, and once they're gone, they're gone.
Mm.
You can't make more appointments. So that's a shame, but unfortunately, very much the reality.
And that analogy of like 5 rooms and various clinicians doing that, not all being GPs, kind of goes into the next question as well, where there's questions about why patients never see the same GP twice.
Yeah, so there's a lot of reasons for this actually. So one of them is patients value. So a lot of patients value continuity.
Yeah.
Continuity was easier to deliver when sort of most GPs worked 4 or 5 days. That was incredibly familiar to most people. If they went in any day of the week, they'd have a particular doctor that they knew were working. In today's society, most GPs work 2 or 3 days. So if you work 2 or 3 days, obviously you've got fewer appointments to be able to deliver. So there might be a doctor or a clinician available for you to see, but statistically it's less likely to be the same person unless you're happy to wait. Because if that person isn't in as often, they've obviously got fewer appointments to actually deliver. So if they've got fewer appointments, then it's either going to be harder to get in with them or take longer to see them. And that's very much the case. We know we have a more part-time workforce than we've ever had. That's partly because of burnout, partly because of issues with resilience, partly because people are trying to develop portfolio careers because they're trying to, we know having a portfolio career stops you from burning out and it improves your resilience. So a lot of people are doing additional things alongside being a GP because the job is more complicated and more difficult than it's ever been. So if you've got fewer real-time GPs because the money's being spent on alternative roles, and if those GPs are working fewer hours, then it's harder to see the same GP, unfortunately.
Okay. And the other thing is why are practices making patients use all this tech? Why can't they just call in?
So I think if you are unable to use technology, or you have a vulnerability, or you have a restriction like a disability, then that's fine. There will be alternative provision. Either you'll be able to walk into the surgery, or you'll be able to call the practice, or whatever the appropriate agreed thing is with the surgery that you're aware of, and there'll be policies around this for every single practice. I mean, it's not a practice decision really. So, in October 25, there was a very clear mandate
Mm.
nationally to say every practice in the country had to do this. So, it's a central government decision that online access has to be available throughout all hours of the working day, 8 till 6:30. And if you're going to force people to turn online access on, they probably are going to use it.
Mm.
So, as a practice, why would I want people ringing on the phone if I've now had to dedicate 2, 3 people to sit here and look at these online access forms coming in? Because I know legally, like my contract requires I have to have
Yeah.
these things active. So, if I'm going to deploy staff there to look at those forms or these consultation requests, naturally I've pulled those staff from somewhere else and I've probably pulled them from the phone line.
Yeah.
So, yeah, if you're being made to do something, that something has become the default, and that's what we've been told to do.
Why does my friend in a different part of the country get access to different services? So why is there variability?
Yeah, why is there a postcode lottery?
Yeah.
Is another way of asking that question, which there absolutely is. I find this really frustrating. I mean, at Valor, we come across this all the time,
Yeah.
right? We work with one service and they've got a fully ICB funded service for what, to be honest, what feels like a luxury.
Yeah.
Doesn't feel like an essential service sometimes, but obviously in that area, maybe it's. And I find this right. I find if you look at an area that's very affluent, I'm always very surprised by what they've managed to arrange because obviously your constituents, if you will, dictate to a large degree what the interest is for.
Mm.
Because a lot of the time, when you're involving a patient participation group or when you're trying to do something that's going to respect what your patients want, it's going to make sense that the offering is different.
Mm-hmm.
So I'll give you a very quick example of this, right? If you live in an area where there's very high rates of people that identify as being transgender, as an example,
Yeah.
it's probably not unusual to hear that there would be more transgender related care services in that area. That
Yeah.
makes sense, right?
Yeah.
So you're supposed to deliver service in respect of what your population wants. So if you have an area where there's lots of elderly people and these elderly people have a very long waiting list for dermatology because they've got lots of skin issues, it probably makes sense that in that area there's a service where they offer funded cryotherapy, where they're freezing these skin lesions off because otherwise they'd be waiting 12 months to see a dermatologist. That would make sense.
Yeah.
And that's what you find. What you find is different areas have different challenges. You have areas that are incredibly rural, and it's very painful for them to get to places if they've got a lack of transport or there's a lack of trams available or buses available. Um, so they will have maybe more remote things available. In a city, for example, things are usually more technologically advanced, more interconnected. You might have to travel for certain things,
Mm.
but in a rural area, a specialist might pop down to your practice once a week to do a clinic. That's what's required.
Yeah.
So yeah, so you get massive variation. There's some level of local decision making as well, because one ICB might feel very particularly about, I don't know. I'll give you a quick example. Actually, there'll be ICBs that are very focused around chronic disease management, and in that area, there's loads of funding being pushed into diabetes because they've got really bad diabetic outcomes in the area. And then you'll get areas like Manchester where they've pumped so much money into patient records. So they've got this, I can't remember what they call it now, the Greater Manchester Shared Care Record or Greater Manchester Patient Record or something like that. But it's very specific to Manchester, where they've integrated some of the records between what the NHS holds and some local organizations. So in the community outside of the general practice, other people looking at the patient have more health information
Mm.
available to review. That's quite specific
Yeah.
to Manchester. So you do have areas where they prioritize different things. And that's unfortunately just how commissioning works.
And just a follow-up question, this is really from me, is how can patients make their voices heard for a practice?
I mean, well, in a practice, there's a requirement for every practice to have a PPG, which is
Mm.
a patient participation group. So if you're not a part of your patient participation group at your practice, you should join it,
Mm.
or ask how to be directed to it. So there's usually a committee or a board or a group of elected people from a PPG, and it's their job to take the patient's concerns, worries, questions, and raise them to the practice. And there's an obligation to respond to those questions, queries, and concerns and give a satisfactory answer.
Mm.
So the PPG is the patient voice for the practice. But there isn't traditionally a PPG for PCNs. And I imagine there will be something that ICBs use similarly to get a patient perspective. I mean, I don't know how they do it, but obviously they would also, if they're putting a policy together, or if they're making a decision, I would assume there's some patient advocacy or patient involvement in that process.
Okay, thank you. And then another one is some patients feel quite frustrated about needing to repeat their medical history at each appointment as they're seeing different clinicians. How would you alleviate that concern, or how would you rationalize that?
I mean, it's really tricky, right? So you have to look at what we class as good practice and why people find it frustrating.
Mm.
So we know that when we're taught to do consultations, we're taught to confirm history and events with a patient, because sometimes things are recorded incorrectly. And actually, the amount of times I've said to someone, it says this in your record, and they said,
I'm
why?
not aware. Yeah.
I'm not aware, right? So you only find it frustrating if you don't see the value in it, which probably means your record's okay.
Mm.
Or or maybe you don't have a significant amount of health issues, because there's not much to clarify. But I routinely, when I go through someone's record with them, will find issues.
Mm.
Down to, I mean, I'll keep talking about health checks, but I've been telling people, it doesn't look like you've had the measles, mumps, and rubella vaccine. And they're like, I'm sure I have. And I'm looking through the record as far back as birth. And every now and then they have, but it's been recorded incorrectly. So then I'll correct it. But sometimes they genuinely haven't.
Yeah.
And so there's value in calibrating and corroborating stories with the patients, but also it helps with expectation setting, because the amount of times I can tell you a booking link has said something like patient migraine worse, wanting support, and then they've walked in the door and said, I'm really, really struggling with my mental health. My boss is being horrible to me at work.
Yeah.
And I'm like, I can see how they're related, but these are two different conversations. One was a migraine optimization consultation, and one is a supporting someone at work, probably with some time off and some medication for their mental health.
Yeah.
Two
Very
very
different consultations.
two very different consultations. So there's value in confirming. I think the way you do some confirming is really helpful. So the way I would do it, and maybe this is the bit we don't do very well, I would say to a patient, look, I can see you have the following conditions on your record. Do you agree? Yes. And I can see you've had a couple of consultations recently about this, this, and this. Have you come about this today or something else?
Mm.
And just set the team so at least they know you have looked at the record. I think the patient frustration is they feel like you haven't looked at the record and you're making me repeat everything.
Yeah.
And if that is the case, that's not ideal, because obviously if you're trying to deliver someone care, you should be reviewing the record in advance so that you've got some insight into what you need to do. Otherwise, if that person was due a vaccine and you've not looked in advance, how would you have got the vaccine ready?
Yeah.
You wouldn't have, right? So there's a level of proactive care that we should be doing.
And one of the final questions here, again, kind of is in line with the theme that we're talking about pressure systems, lack of capacity, really, about the perception that staff. Why do staff feel rushed?
I mean, because they are.
Yeah.
So
Simple as that.
it's sometimes as simple as that, right? Like, if you've got a 10-minute appointment to see someone, and look, it comes down to a lot of things. On one hand, that person could be running behind, and they could be running behind because they were late. They could be running behind because, unfortunately, our IT infrastructure is shocking and the computer took 10 minutes longer to load than it should have. Or because, like in my practice, one day, the complete connectivity for the health record just went.
So no access to nothing.
So basically, for the whole morning, there was no patient record system.
Hmm.
So what do we do then?
Confirm their medical history.
But, I mean, you would like to confirm the medical history, but you're only going to get one side of it
Yeah.
because you don't have the record to confirm it against.
So what do you go back to paper?
I mean, we
or
literally pulled pieces of plain paper out of the printer and just started being like, could you give me your name? Could you give me your date of birth?
Yeah.
And could you tell me some conditions? And we were writing the record as if we were in hospital.
Yeah.
You know, when you do like your past medical history,
Yeah.
history of presenting complaint, etc. So we ended up doing that. I mean, I know surgeries in that scenario that just cancelled everyone's appointment and just
Yeah.
said, we are unable to consult you because we don't have your record. If we want to prescribe you something, we can't even check your allergy status.
Yeah.
And I mean, I take a very practical approach. We'll pull out a piece of paper, do this. The problem then is you've done the clinic as normal.
How are you going to convert that into the
Someone's
record?
still
Yeah.
got to retrospectively transcribe it into the record, haven't they?
Yeah.
And if you've lost that piece of paper, what do you do then?
Yeah.
You've now delivered care for that person. You can't record it. You've lost the piece of paper. You don't know what time you saw them. The notes are not, um, they're not, they're not correct in terms of accuracy. And actually, there's an argument. It's just safer not to consult the patient.
Mm.
There's an argument. I'm not saying it's the one I agree with, but I can see why people choose to do it because you are taking risk on yourself.
Yeah.
But these are daily occurrences that we deal with. And maybe it's just the case that, sometimes patients take their time walking into a room, which we're not going to blame them for. And then they decide the coat's going to come off and then the scarf's going to come off and then they're going to set it down very nicely. And I've had people that have come into a 10-minute consultation, arrived 5 minutes late, took 2 minutes to settle into the chair,
And then start.
and then start with 3 minutes to go and want a full consultation.
Yeah.
So there's lots, and I'm not saying that to be flippant, but I'm saying people are very aware of what they're seeing. They're not very aware of why they might be seeing it.
Yeah.
And also as a clinician, if I've had an emergency with a child and I've run 10 minutes late, my next patient's waiting, they're irritated. I know they're irritated, but my next 3 have arrived as well.
Yeah.
So there's so many reasons for why that could be the case.
Yeah. We could probably have another episode on just the IT infrastructure, because I don't think a lot of patients are aware of like how fragmented it is and how many actual separate systems you have to log into to get the whole record effectively. But that's probably a topic for a different day. I want to just say thank you, Valid, for giving us your insight, answering these questions. And just for the listeners out there, it'd be really appreciated the fact that to like and to subscribe to the channel, mainly to share some of the knowledge that we're sharing and actually just broaden the kind of breadth of audience that we're getting. And we like to do these kind of quick fire questions as well. So if you do have any questions you'd like us to answer or delve deeper, please put them in the comments, and we look forward to seeing them. Take care.
Thank you.